project objectives and some discussion prompts to help shape the conversation, but then we're going to jump right into taking your comments, since we do have a big crowd today. And we'll remind you at the end as well, but the email address where you can submit written comments is ratesettingeval@maine.gov. You want to move to the thank you. Just to level set, as Michelle had said, the purpose of the evaluation was to develop a system for establishing and maintaining rates that are sufficient to support providers as well as ensure access for Maine Care members. And then also to evaluate Maine Care's rates in the rate setting system to develop a plan for the creation of a comprehensive, streamlined, and coherent system for the future. Looking at where we're at in the timeline, we had the first provider listening sessions in October. If you were able to join us then, we've had member listening sessions in November, and now we're here in the second phase of provider listening sessions. We did release the cataloging and benchmarking report in November, and right now we're working on the January and February reports, which are interim findings, and then a final report that will include, like we had said, a baseline recommendations, a review of the process, and recommendations of a priority list. So the rules of engagement for the meeting. Our role is to really ensure participants keep their comment on within the announced time limits. This is a much larger meeting, but I'm going to initially ask that everyone please be respectful. If you're running long, I will signal to you. By long, I mean you've prepped over it until like 10 minutes. And just be respectful that other people would like to speak in a meeting this size. I don't want to start cutting people off, but if you see me waving at you, that might be that I'm giving you your couple-minute warning before I ask you to wrap it up. Ensure the comments pertain to the topic. We are recording the meetings to make sure that we get all the comments correctly captured. Your role is to introduce yourself and your organization and any services that you provide. This is to help us associate your comments to the right services and sections. If someone says something you agree with, it's perfectly fine to say I agree with them and not restate their previous points. And then, like I said, just respect each other and the time limits if necessary. The purpose of today's meetings is to really look for and get feedback on those additional points that are important to understand for consideration regarding rate comparisons, recognizing that it's very difficult to compare rates across states and across systems without a lot of context. And then to give us some information on the sufficiency of your current rates and any issues related to rates and their impact on access or sustainability. To that end, we have a couple of discussion prompts just to help you think about how you can give us feedback that we can incorporate into the recommendations. Are there assumptions or costs that are critical to consider that may be unique to Maine that wouldn't be reflected in another state's rates? Are there differences in payment methodology, services that may explain some of the differences in certain rates, though it may not be evident by fee schedule or service descriptions? Are there services where current rates contribute to access or quality issues? And do these issues then impact other parts of the service system? So these are just a few prompts to help you, but we will now open it up to comments. If you would like to make a comment, please raise your hand, or if you cannot find the little hand symbol, you can chat to us in the chat box and Jillian will unmute you.
Okay, first up, I had Paul Dan.
Thank you. Can you hear me?
Yes, we can.
Good afternoon. Thanks for the opportunity to be first up and to comment. So I represent NFI North. I'm the executive director of the agency, and we provide PMI services as well as Section 65 services in terms of day treatment and HCBT. So I have a couple comments about Section 65 rates. First and foremost, I want to make sure that any rate analysis that's done is not based on historical costs in terms of HR expenses, but moves much more towards a livable wage frame. I think one of the challenges that we have in delivering HCT and having enough BHPs is the fact that our current rate does not really support livable wages. And so there's parity issues in terms of what we're able to pay people for similar work. This work actually is quite complex at a master's level. We're talking about for the in-home and in-community part, we're talking about people with master's and bachelor's degrees, or people that have been trained being out in people's homes, working evenings and weekends and things like that. So I think we have to look at what's a livable wage and what's effectively a parity for payment in the rate consideration. So please, as you do your comparisons, be aware that Maine has a higher livable wage requirement than some of the other states that were looked at in the comparison. The other thing is that we have a situation where when we build ultimately the rate, it's based on billable hours. And I think because we have geography that creates some complexity, that we have to look at what the percentage of billable hours are in the ultimate rate. I think in traditional service array, 22, 23 billable hours could be reasonable. But if you're talking about in-home and community-based treatment, where you have folks traveling distances in order to meet with the clientele, those unbillable hours, because of transportation, have to be built into the formulary. For example, if someone drives an hour and a half to see a client and there's a no-show, then you've got 3 hours of that person's time in a given day that's unbillable. So in some areas of our state, that's more a phenomenon that is encountered than in other areas. So if you're looking in the northern reaches, there's more time between clients. So I think whatever rate we build from a billable hours standpoint for each FTE has to take into consideration the geography that we're dealing with. Also, with regard to BHPs, there's multiple standards in terms of how a BHP is approved or able to be used for billing purposes. And I think it would make sense to look at a system where we consolidate the standards or expectations for BHPs in order to simplify that. To do that, though, we'd want to make sure that we would grandfather any existing BHPs if there were new standards, for example. We wouldn't want to negatively impact the workforce, but I think it would make sense to have a simplified workforce requirements for the BHP positions. There has been some talk about maybe looking at going to another type of billing approach, a per member per month, for example, versus an hourly per diem. That's certainly something that would be interesting to look at in the overall rate structure. Of course, a per member per month methodology would require a certain number of enrollees in order to make that sustainable. So those are my comments. Thank you so much. I appreciate the opportunity.
Thank you, Paul. Next up, I have Ben Strick.
Yes, hi. I'm calling from Suburban Services about our Assertive Community Treatment Program. The rate study references a rate from Montana of $49.05 per day, but it's based on being able to bill every day. In Maine, our rate is based on a 21-day month, or only being able to bill for a limited number of days. So an equivalent rate would be closer to $70.07 if you compared the two, the Maine rate to the Montana rate. Also, if you go through the fee schedule that Montana that was linked, it includes a separate daily rate of $117. as well as 2 weekly rates. So it's hard to say whether the 49.05 rate quoted in the study is comparable to Maine's existing ACT rate. Does that make sense?
Yes, it does. Thank you for your comment. We've written all that down to look into.
Thank you so much.
Okay, next up I have Scott Tash.
Great, thank you very much. I'm calling from UCP of Maine, but also representing the Maine Association for Community Service Providers on the Children's Committee. At UCP, we offer many of the Section 28 and 65 community and center-based services that are listed, which I'll be focusing on those here. I do agree with the nature of the rural areas and the travel issues having an impact on the billing and billing rates, as well as a better review of the educational requirements for BHPs are needed. For Section 28, specifically on the BCBAs, this rate was developed several years ago from the Burns and Associates, with the primary driver of the rate being a high level of productivity expectations, and certainly in the community setting, that is difficult to achieve, making it difficult to hire and retain BCBAs in that particular service when we're competing with school systems or other center-based settings that don't have the travel issues. For on this, there wasn't listed a specialized 28 one-to-one rate for the BHPs, so we would certainly want to make sure that is evaluated through this process as well. But regarding the regular 28 BHP rates, those were also calculated previously prior to the requirement of EVV coming next month. And I would say that EVV adds a significant burden in terms of administrative work, as well as time and equipment needs from the BHP and therefore the providers. And that should be reflected within the rate or allow for some additional add-on to cover those unfunded items. I'll echo that the nature of the BHP work within Section 28 does lend itself to primarily nights and weekends, entering the homes of clients and clients' families. Those factors alone contribute to the instability of the available work hours due to cancellations, et cetera. However, the weather and the rural settings also contribute to those inconsistencies. Those factors, but coupled with the difficulties around the waiting list procedures, make it almost impossible for our BHPs to count on those consistent hours week to week. A rate which allows and supports a higher level of non-billable time would encourage those additional full-time options, reducing turnover and improve the consistency of service ongoing. The recent change in the educational requirement for Section 65 BHP has an impact on availability of Section 28 BHPs as well. While possibly helping Section 65, it does take away from the potential pool of applicants for Section 28, given that the work schedules and available time generally overlaps from service to service. Related to Section 28 groups, there's very little application of group offerings, even outside of our current COVID environment. Group settings require much more administrative burdens, probably double as far as the paperwork and oversight, with very little in additional reimbursement. The only way we and others have been able to initiate group services is with additional funding sources such as grants or others, even though group settings can be very effective. Jumping to Section 65, the collateral services, both the BHPs and clinicians. Again, like Section 28, the BHP is rarely a full-time position. And to that end, pay and reimbursement rates needs to be competitive in order to begin to attract and retain employees. As far as the clinicians go, while there are no comparison rates listed, the community-based clinicians are competing with entities such as FQHCs and schools on hiring and retaining those clinicians, and the schedules, again, being in the homes, being many times nights, weekends, makes it difficult to retain and hire. So those rates need to be set in order to be competitive. The day treatment BHP rate, without a full understanding of the comparison rates, it's very difficult to discuss the differences and why there's such a range from state to state. But as far as the day treatment center base goes, for Maine, the BHP rate includes 100% of the reimbursement, regardless of whether the educational pieces are being fulfilled. Whereas in other settings, school settings, there's additional tuition reimbursement for that. It would be helpful to know, with such a range of comparative rates, whether the additional education funding is included in those rates. And also with the groups, again, little application of groups, the same reasons for Section 28, additional administrative burden with very little additional reimbursement bump. Thank you.
Thank you, Scott. Let's see. Next up, I have Jillian Jolliker from the chat.
Can you hear me?
Yes, we can.
I'm thinking we're not going in any particular order, right? We're kind of...
We're going in order of who raises their hands, but not section-wise, no.
Okay, perfect. So I just want to point out that our organization was one of probably several that opted to close our 28 and 65 HCT services. So we're not going to be talking about those. That was sometime in the last year or two. My name is Jillian Jolliker, and I'm the Chief Operations Officer at Assistance Plus, and I'm here to speak about the Section 17 daily living support rate. The DLS rate is not sufficient due to the following: a high administrative burden related to keeper eligibility process that's unique to Maine, and clients now have decreased hours for this program, making case requirements much higher. There is also an access issue on a result of this for clients, as they do wait prolonged periods of time for staffing or complete staffing. And this is directly related to low wages. The benchmark data report does not seem to accurately compare DLS services in other states. The benchmarking report lacks sufficient data to make a good comparison. This program has consistently ran in the red at a loss for providers, and many providers have closed this much needed service over the last few years. There also continues to be a shortage of providers, with an immediate concern for this being a high priority item and a much needed service to look at first. I know our organization is, the clock's ticking for us due to a critical short funding.
Okay, thank you, Jillian. Next up, I have Douglas Patrick.
Hello, thanks for the opportunity to speak. I'm a director of behavioral health and case management at Woodford's Family Services. I oversee the adult case management program for developmental disabilities, but also the children's behavioral health home program. And I just wanted to speak to the fact that it would be much more efficient and effective if Maine would consider having a monthly rate for available to provide something like behavioral health home services or case management for adults with developmental disabilities. The expectations are as much, if not more, complex of the coordinators and the case managers in the adult case management program, who are in effect responsible for managing waivers for individuals, which is a very complex system, and the current rate has not been adjusted much in many, many years, and does not account for the complexity and the administrative tasks that are required for adult case managers. Also wanted to comment on 65 home and community-based treatment. Although there was somewhat of an increase for the behavioral health professionals in that program this past year, the rate for the clinicians has not been touched in excess of 10 years. And to expect that these programs continue to function at this point is not reasonable. For the 65 home and community-based treatment clinicians, as was mentioned earlier. This is a very complex program in which there are significant needs in family systems and with children who would otherwise be hospitalized or in residential care. To avoid increases in hospitalizations and reduce the numbers of children in residential treatment and on residential treatment wait lists, it would be a benefit to be able to attract and keep more seasoned and knowledgeable clinicians in that program. The current rate does not even sustain keeping entry-level clinicians in the program who often leave after a year or two providing services. Thank you very much.
Thank you. Let's see. Next up, I have Nathan Miller from the chat.
Hi, thank you so much for letting me speak today. My name is Nathan Miller, and I am Senior Program Director for Spectrum Generations. The executive summary on comparable rates was really interesting, but I would really caution you to look at local environments and consider our competitive market here in Maine. For example, case management, which is what I'm speaking to, was higher than the average comparison rate, but at our current rates, we're struggling to fill positions and to serve all the consumers that we have. There's just a lot of factors that aren't accounted for in the comparison. For example, the minimum wage in North Carolina is almost half of what it is in Maine. There's other factors too that need to be considered. Taxes, services covered, what you can bill for, modifier codes, actual costs, regulatory requirements, geography, which has already been mentioned, required benefits, workers' compensation, licensing, education, training requirements. I think when you look at those, you'll find that the cost of doing business in Maine is a lot higher, and we need to be able to attract people to fill these direct service positions. Thank you for your time.
Thank you, Nathan. Next up, I have Margaret Longsworth.
Hi, my name is Margaret Longsworth. I'm the Director of Mental Health and Clinical Services at OHI. We provide Section 17 community integration and skills development, as well as 92 behavioral health home services, PNMI, Appendix E, and a number of other Clubhouse and ID services. I will begin by saying that the behavioral health home rate does seem to sustain the service, but my concern with that is adjusting it to keep pace with inflation. I would second the comments made by the woman from Assistance Plus regarding the DLS rate. We used to provide DLS services and let go of that a number of years ago because we just couldn't make it work financially, whether we ran it as a big program or a small program. We were always at least 10% in the red. One of the important things about DLS is that it is a service that has CRMAs, Certified Residential Medication Aides, in there, and they can be responsible for doing medication administration. And when you're using DLS to do medication administration, you tend not to have people always there for long periods of time. It would be, perhaps the rate would be sustainable if every time somebody got DLS service, they got 3 or 4 hours worth of DLS service, but that's just simply not the case. And then the impact of the geography is really challenging. We let go of CRS services just a month or two ago. Again, just not able to sustain it with the current rate. And I would point out that CRS is a critical service for both getting people out of the PNMIs efficiently and also taking the people directly out of the hospital who will not go into the PNMIs. I believe that when CRS was first developed, the thought was more around it being a step-down service, but that's not how it's always used these days. And those people who were going into the CRS service directly from the hospital were often some very tough customers. You wouldn't necessarily find them every day, therefore you can't bill if you can't find them. And we just couldn't make that work. I would also like to say that within the Section 17 service, there is an allowability for certain nursing services, but those really seem to be put in there perhaps more for ACT. They're high-level nursing services, nurses that cost a lot of money, psychiatric nurses, advanced practice nurses. We really need to have some RN support in there. If there's something that we've learned from the behavioral health home service, it's that the nursing supports really help a lot. And I think any place you have a CRMA giving medication or trying to navigate through the complexities of main care, dropping a person's medication or authorization or something, having that ability to call on a nurse periodically is really critical. Wage compression is certainly an issue. Maine's minimum wage is, as of January, will be higher than all the comparison states that were used in the this modeling. For DLS, both of the comparison points are in states whose minimum wage is the federal at $7.25. So I don't know how useful that is. And the one from North Carolina, that's the $2.69 a unit. I have to wonder if that service is even a service that they are providing, given the reimbursement for that, or perhaps it's a part of something else. I'll reiterate the comment that I made this morning about skills development, in that when DLS was first developed, it was only supposed to be something that a case manager could refer to, with the assumptions that the case manager would do the assessment and the treatment planning. Then the system realized that we had violated the rights of recipients of mental health services. It was split off as a separate standalone service, yet the rate was never adjusted to accommodate the increased expenses of the assessment and treatment planning components. I think that is all for now. Thank you very much.
Thank you, Margaret. Next up, I have Amanda Parker.
Hi, my name is Amanda Parker. I'm the program manager for the community case management program at Living Innovations. Couple points I wanted to make. Targeted case management in Maine has several different disability categories with very different expectations of the way the service is delivered, as well as the level of involvement required from the case manager. The Office of Aging and Disability Services, as well as Maine Care, has a very high set of expectations to ensure a comprehensive service is offered to protect the health safety of the individuals, as well as to focus on true person-centered planning. Another point to consider is that IDD case management in Maine is conflict-free and has been for several years. The other states you provided comparison to do not appear to be offering conflict-free case management, or do not offer targeted case management once the individual engages in an HCBS service. Moving forward, it seems that the HCBS setting rule, this will be a requirement to offer. Also, to piggyback on what Margaret just said about wage compression, the last time that rate was reviewed was in 2009, and it's very difficult to keep up with inflation for what it costs to actually employ people at a livable wage. So thank you for considering those points.
Thank you, Amanda. Next up, I have Karen Turjan.
Hi, thank you for allowing me the time to speak. I'm Karen Turjan. I'm one of the VPs at the Opportunity Alliance, overseeing primarily our community-based programs. I wanted to really echo a lot of what has been currently said about the case management and the care coordination work that's done. We operate a Section 13 and Section 92, both adult behavioral health and children's behavioral health. Primary concerns that we have in those areas really is around requirements for education and training for hiring or to have within a certain amount of time for people after they're hired. So thinking about bachelor's degrees and MHRTCs and additional requirements, it's impacting ability to hire and retain staff based on the current rates and what we have available for salaries. As a result, I think many of us are feeling this across the state, and that we have vacancies and they're becoming increasingly more difficult to fill. And that ends up impacting the clients who are waiting and needing service. We're increasing caseload numbers in order to try to keep up with the demand, and it impacts morale. And especially during this time of the pandemic, the staff are on the front lines and are doing some, I would say, more difficult work. It's difficult to begin with, but with what they're facing currently, reduction in access to other types of services and needs, it's becoming more strenuous and straining for them. In addition, I wanted to speak about the opioid health home that we operate and have some specific remarks about that. So we would like to see that there be payment for drug screens instead of expecting the programs to be making the payments. It's not anything that's currently included in reimbursement. So we would love to see that be a part of that. And, potentially if it could be included in the client's main care to cover the cost, or be included in the reimbursement. Currently, it comes out of the monthly rate that we receive. It gets to be a little more costly because there are requirements around the number of screens that people need to have over the course of a year. And so it, especially now where we're struggling with being able to see people, getting the screens completed. It would be nice if during the pandemic, if we were able to have some kind of accommodation around the requirement of that, because without it, we're not able to fill. We're also would like to see a reimbursement for a full-time case manager position, rather and have that be part of the integrated care instead of the current patient navigator position that's included, and have an added reimbursement salary for that. It just makes a different approach to the integrated care that our team and teams and other programs provide. We'd like to see reimbursement for full-time counselors who are both certified as LMSWs, LCSWs, LCPCs, and their CADC and LADC. This position should have the background to provide dual diagnosis counseling to truly provide integrated care. An acceptance of trauma and mental well-being as part of the recovery must also help to pay the salaries of the people qualified to address the level of care. We see this clinical approach as an integral role in the whole person service. And lastly, partial reimbursement for clients engaging in one aspect of the program. Currently, it's challenging to meet all that's required. If the client only meets with a counselor, a MAT prescriber, RN, case manager, or peer, our hope would be that there should still be reimbursement for the work that's provided compared to the current structure. There's a significant amount of work going into engaging clients, especially during the pandemic, and payment should be rendered for such services. Currently, there are times that we're not able to bill for work because a client may not have met with the counselor the specified number of times, and not because the staff were not trying, but just because of life situations. We'd also like to see there to be acknowledgement around the strict requirements, not being trauma informed. People should be able to enter the service based on their current need, and we'd like to see that providers should be paid for meeting clients where they're at, since they're still providing them a service. Thank you.
Thank you, Karen. Next up, I have Matthew Siegel.
Hi, this is Matthew Siegel from Maine Behavioral Health Care. I'm the Vice President for Medical Affairs for the Autism and Developmental Disorders Services. I have one comment on medication management, and 2 on children's behavioral health day treatment. So on medication management, those services are ones where the current rates contribute to access issues. We've seen provider after provider cease to provide outpatient medication management services to children. I believe, examples being Spurwink, and more recently, I believe Sweetser curtailed their services in that area. And so there's very few of us left providing that. So that is a rate that, while it appears to be higher than other states, by the comparison, the proof is in the pudding. And we are seeing a continued lack of access to children's medication management. My other comments are on Section 65, Children's Behavioral Health Day Treatment. The first comment is there is no reimbursement methodology or rate in that service for BCBAs. There is a rate and methodology in Section 28, but not in Section 65, and this does not make any sense since both of those services can be applied to the population that has been shown to benefit from BCBA services. So that's a missing component. The second comment is that in children's behavioral health day treatment for Section 65, there's no reimbursement methodology for family therapy. And so there is no reimbursement to generalize the skills and improvements that are generated during that 6-hour day. And it is a ethical requirement of behavior analysis to generalize skills. It's also obviously a clinically sound practice. And there's no reimbursement, there's no way to reimburse for working with the family. So there's no family therapy. There is a monthly, once a month payment that could be applied for psychoeducation. However, it's low, and once a month is not really a useful methodology, and it's unclear where that came from, that it be once a month. It appears arbitrary. So those are my comments. Thank you very much.
Thank you, Matthew. Next up, I have Kate Marble.
Hi, this is Kate Marble. I'm the Case Management Program Director at Health Affiliates Maine. I oversee Section 17, Community Integration, 13, Targeted Case Management, and 92 H for children and adults. A lot of what I've heard about hiring I completely echo. I just wanted to add to that one of the challenges that we're having also in Maine that I don't know if is the same in the other places that you looked at was that we have such a high aging population in Maine. And so many of our experienced professionals are retiring. So we're spending a lot of time onboarding new staff and making sure that they're trained, all of which is not really encompassed in the rate of pay that we have, as well as a significant amount of time it takes for supervisors to supervise someone clinically who is less experienced. The other things that I just always want to make sure that we're talking about is that when we're talking about a rate of pay, Maine Care has a lot of items that are considered part of the billable rate that I don't know that other states have. In fact, we didn't even have them several years ago. They've really, over the last decade, as I've been directing the service, I've seen them increase over time. Just a couple examples of that. I'll put more in my written comments, but for example, T-Pro and the level of detail they're requiring us for each utilization review can take up to 30 minutes of, again, not directly billable time. So we either have to pull someone out of the field to complete that or hire administrative support staff to do that. That has increased substantially over time as they continue to add additional questions and layers to that often are repetitive. And then also right now we're managing a wait list because of the health professional shortage within our services. And if we get a referral that we cannot place, we're required to do an active referral to another agency with an immediate opening. This is incredibly time consuming as there's no central program that tells us when an agency has an opening. So we're doing a lot of phone calls. The referral information is not consistent between organizations and often requires us to leave voicemails, sending letters, for example, when phone calls fail. All of this is for a client that we never even serve. So it can't really be part of the billable rate. There's just no compensation, again, for something we're expected to do in order to stay as a licensed mental health agency in the state. And then just to echo the no-shows within the main care population, when you're comparing private insurance populations in Section 65, for example, they're very difficult to compare. Main care clients have a much more significant rate of no-shows for appointments due to the severity of their situations and transportation issues. And we have a failed transportation system in Maine for main care services, and therefore people end up not showing up even when they're trying to show up. And again, it's difficult to continue to keep the billable rates what they should be in order to make a livable wage. So that's all I have for comments at this time. Thank you so much, and I certainly echo everything that's been said earlier.
Thank you, Kate. Okay, next up from the chat, I have, Ray Nagel.
Hi, can you hear me?
Yes, I can.
Well, thank you for calling on me. And I'm the executive director of Independence Association. And I would like to talk about Section 13 as it relates to adult and children's case management, particularly on the things that are not billable. A great deal of the case managers have to work as a rep payee, and that is not a billable service. Transportation has to be applied for, and a lot of times people served are not eligible for the net transportation, and the person of last resort is always the case manager. I'd like to also point out that whenever the state has a new initiative, has a new anything, that initiative, that action is almost always by default given to case managers to do. And whether or not that's billable, you have to be extremely creative to make things billable. Any type of no-show visit at a home is not billable. Documentation of notes is not billable. We're going to be going to a new electronic medical record system called Evergreen, and all of the training for that is not billable. As a matter of fact, training is not billable, but you have to keep them up to keep your license. The 3-person committees, you can bill, but you have to wait in the lobby forever. That's not billable. I can give you about 40 items that I have listed here that are not billable. And the last thing I want to say is that the state really needs, as far as adult case management is concerned, they really need to determine what they want to be. So ODES has one expectation for adult case managers, which is an easier expectation. No, it's a more challenging expectation than the main care expectation. And I'm not sure which one should prevail, but I really think that the easier of the two should prevail because the requirements to get accredited are beyond the envelope, I believe. The turnover in case management, I haven't officially recorded it, but it is now almost at the rate of our direct support professionals. And I've confirmed that with other agencies. Given the shortage of direct support professionals in our state, the wages for them are going up, and now they are within the same scale as case managers who require significantly more background and education to do their jobs. And I think that all of that needs to be taken into consideration. The especially the trainings and the rep payee. Those are two things that I hear our case managers saying all the time that they don't want to do because they don't get paid for it. And it's true. So thank you for letting me have my little soapbox, and I appreciate you taking these items under consideration.
Thank you, Ray. Next up, I have Pete Plummer.
Hi, I'll be quick. I was going to talk about adult case management. There's just one item in specific, rep payee, that Ray Nagel did a superb job in explaining, but I just want to add a little bit more to the rep payee discussion. Everything he said was very true and very appropriate, and you know, we take on these cases because these consumers need help, you know, with their financials, and that's the reason why we do the work. But it's not only all the work that the case managers put into rep payee. There's an awful lot of accounting and keeping track of all the revenue and expenses for all the different individuals, and tracking them to a great level of detail, which we have to do, you know, in accounting, and reconciling every month. And then we get audited by Social Security, and you know, they send in DRM to review our cases to make sure we're doing it right. So it's an immense amount of work that goes into rep payee. And I've asked DHHS or ODES multiple times to please make this a billable event, because, you know, we struggle with the amount of cases we have, and it really limits us taking on more cases because of the amount of work that goes with it. So it's more, you know, it's a capacity issue too for organizations that can only do so much, because it's a non-reimbursable service that we're providing. And clearly, you know, if you're not going to adjust the rate, then please adjust the things that are billable to make it a system, you know, something that can be done by all. And that's really all I wanted to add. So thank you for your time.
Thank you, Pete. Next up, I have Mallory Shaughnessy.
Hi, thank you. This is Mallory Shaughnessy, Executive Director at the Alliance for Addiction and Mental Health Services. And I'm going to comment again on this section, one similar comment that I made on some of the other sections, and then I have a few other specifics to this, but concerns with that whole overview of this, where we look at the comparisons and we talk about outliers. And in your writing, you talk about outliers as anything that's 120% of the comparison as a high outlier, but it has to be less than 40% of the comparison rate to be flagged as low, as opposed to 80%, which would make more sense. 120, 20% one way, 20% the other way. So many things that are actually very low are not being flagged immediately as low outliers. So I just want to make that point on this batch of services as well. And just overall, Maine is spending only 83% of what it should be spending or would be spending for adult community-based behavioral health services if they were paid using the comparison rate. So overall, those rates are low, and that's not even taking what many people have already mentioned, which is the wage differentials between different states and the competition here within the state with FQHCs and hospitals, et cetera, and very few people to employ. And I would just say again, I think somebody mentioned this, but looking at the wait lists and the time it takes to get into an appointment for a service is the biggest indicator of access. And I think that looking at children's home community and others, we see hundreds of kids on wait lists for those services. So it's an implication that the rates are not providing adequacy of network, which Medicaid, CMS demands an adequate network. So those are huge indicators. It also reduces the quality of the service that people are getting when they ultimately do get into a service. If you can't bill for and do those ancillary collateral contacts that people are mentioning with family, with schools, et cetera, to provide that full wraparound support that somebody needs and stabilize them. And without having any kind of automatic adjustment built into any rates for cost of living increases, for things like the referendums that raise hazard pay or raise minimum wages, or legislative initiatives that increase benefits that have to be supplied to people working for you. If there is no kind of automatic adjustment to look at any of those things, all of that eats away at the actual level of service that's able to be provided. And a couple of specific things too. I know ACT was mentioned once before, assertive community treatment, but looking at reformulating the actual rate structure and the expectations to meet the fidelity of the model is really needed. Some sort of a per member per month rate, something doing prior auths on an annual basis. It's a chronic persistent mental illness that's being addressed here, not an every 90 days reauthorization. So an annual reauthorization would make a lot more sense and reduce the administrative burden. Being able to overlap those services when somebody is going into the hospital or coming out, or into jail and coming out, for coordination is part of the fidelity model, but it is not a billable service. So those expectations of people doing work, of providers doing work that is not billable, just totally reduces the quality of the services that people are getting. And when you reduce the quality of the services people are getting, they don't maintain the stability as well, and they do end up in the emergency departments, and they do end up in jails. These are things that we see constantly. One other piece that I want to just put on the table here is within treatment foster care. Providers are seeing a huge issue with treatment foster care liability rates escalating at 300 and 400% of what they have been, because of statutes that are changing around the country, taking away sort of the look back for lawsuits around sexual abuse and things of that nature. National organizations national agencies that do provide the liability insurances are upping those rates tremendously. And we are seeing many providers for the state of the intermediary to the treatment foster care families are looking at having to reduce or get rid of that service provision anymore, because they can't afford the impact of that. And that needs to be taken into consideration in any kind of rate structure review. It's just a critical piece. So I think, many of the other things that I would say have already been mentioned: the turnover, the onboarding, the cost of training, all of these things are unbillable. And when you don't pay people enough, you lose people, and you have constant turnover, and are constantly having to take those expenses. And the whole thing is just bringing the quality of the services down across the board. Thank you.
Thank you, Mallory. Next up, I have Ken Olson.
Good afternoon. My name is Ken Olson. I'm Executive Director for Kids Peace, but part of my comments here are also reflective of the fact that I am the Clinical Director for Kids Peace nationally, where we provide community-based services in 7 other states. And I think that some of our experience in some of those other states may be relevant here. At the risk of being somewhat committing a cardinal sin of comparing New York to Maine, I'm going to take that risk. In fact, I've learned from my work in New York that upstate New York actually looks an awful lot like upstate Maine in terms of the rural challenges of delivering behavioral health services to, you know, to that part of the country. Recently, within the past couple of years, the state of New York has recognized that they wanted to expand access to many of the community-based services that we're talking about in this particular section this afternoon. Services that compare to HCT and targeted case management are collapsed together in something called Child Family Treatment Support Services. CFTSS is the acronym. And some of what they have done with respect to rates as they have developed those programs in New York may be instructive here. For example, in the interest of expanding access to those services in New York, the rate study that was done of what it would cost to provide those services was enhanced by 25% in an initial period of time so that providers could afford the startup of those kinds of services. And if we are looking at services such as HCT here in Maine, where we're trying to expand access, that might be a consideration to develop that methodology, include that in the rate setting methodology. The other thing that's interesting in New York is, and again, in the interest of providing services in rural areas, there is an offsite differential. So in addition to the standard base rate that a provider gets for delivering an HCT-like service, when that service is delivered in the home, there is a differential that's provided to the agency providing the services. Another consideration in New York, there is an upstate rate and a downstate rate that reflects the differences in cost of living in the New York area, in the New York City area, as opposed to the rural areas. One might wonder whether such a differential here in Maine would be helpful to resolving some of our problems in delivering services to rural areas. With respect to, I want to echo Mallory's comments about therapeutic foster care. That is going to be, I believe, a considerable challenge going forward for agencies providing that service, both here in Maine and in other locations, to continue to be able to afford that, given the increase in liability insurance rates that are being attached to it. Very, very few liability insurers are even willing to issue those policies now, or so we're finding. I think we will need to look for a solution to that here in Maine. I'm not sure what that solution would be, but it probably needs to be considered as you look at rates for that service. So those are my comments. Thank you very much for the opportunity.
Thank you, Ken. Let's see. I'm not seeing any new hands. If you had raised your hand previously and are done, if you could lower it, or if you want to speak again, if you could lower and then raise it again so I can kind of tell. Okay, Julia, I'm not seeing any new hands.
Okay, thank you everyone who has given comments. We truly appreciate the time you took to do that. I want to open it up just one more time. If anyone who would like to speak, please raise your hand. If not, we welcome all written comments at the ratesettingeval@maine.gov email address. And we truly appreciate all the time that so many of you took to come to the meeting this afternoon. I'm not seeing any new raised hands, and no one's chatting to me. Jillian, if you're seeing anything in chat. Comments open to the 11th. Yes, I believe so, that that was the extension, was to the 11th. Great. Well, thank you all so much. We truly appreciate the time that you have taken to sit through 2 of these now with us. So thank you very much. I hope you have a good rest of your afternoon.